My name is Jaclyn LoPiccolo. I am a thoracic oncologist at the Dana-Farber Cancer Institute, and I will be talking today about lung cancer in those who have not smoked. I'm thrilled to be here and would like to thank LUNGevity for the opportunity to talk to you about this important topic. Here are my disclosures. So many of you may remember Dana Reeve, the wife of the famous Superman actor Christopher Reeve, and what a shock her lung cancer diagnosis was at the time in 2005, given that she had never smoked. She unfortunately passed away at the age of 44 in 2006. And also in 2005, news anchor Peter Jennings was diagnosed with and passed away from lung cancer after quitting smoking over 2 decades prior. And today, certainly, it seems we're encountering many cases of lung cancer in people who have not smoked. Two celebrities here recently went very public with this diagnosis, which you may have seen. And just kind of giving an outline for this talk and topics I'll try to cover and questions I'll try to answer to the extent that we know the answers. So in part one, what is LCINS? Or lung cancer in those who have not smoked? How is it different from smoking-related lung cancer or tobacco-related lung cancer? Part two, what causes LCINS? Are rates of LCINS increasing? And what might be risk factors? And part three, what makes LCINS different to treat and to diagnose? What is important to know? And could this be prevented? So first, I think it's helpful to review current eligibility criteria for lung cancer screening with low-dose CT scans in the United States. So first, for age, you have to be 50 to 80 years old. And in terms of smoking history, you either have to currently smoke or have quit smoking within the past 15 years. And then more specifically, that smoking history needs to be 20 pack years or greater. And what that means is you take the number of packs of cigarettes smoked per day times number of years smoked. So if you smoked 1 pack a day for 20 years, that's a 20 pack year history. If you smoke 2 packs a day for 20 years, that's a 40 pack year history. So you have to have a 20 pack year history or greater of smoking to qualify or to be eligible for low dose CT scans for lung cancer screening. And secondly, I think it's helpful to be mindful of terminology that has changed when talking about exposures in lung cancers. So in an effort to mitigate the stigmatization of patients with lung cancer, the International Association for the Study of Lung Cancer released a language guide in 2021 that includes replacing the term smoker with person who has smoked and never smoker with person who has never smoked or has not smoked. And then within that, I think some definitions to look at are helpful. I have found that there is sometimes confusion around these terms. Most importantly, never smoking, sometimes referred to as non-smoking, refers to somebody who has smoked less than 100 cigarettes in their lifetime. Former smoking is someone who has smoked greater than 100 estimated cigarettes in their lifetime, but has quit 12 months or longer since the time of their cancer diagnosis. And I think more often what people are using to refer to former smoking is something called long-term former smoking, which is somebody who has quit more than 15 years prior to a lung cancer diagnosis. So similar to the Peter Jennings case. And then there are other terms such as remote smoking. So these are persons who have smoked briefly or socially as adolescents or young adults, but still more than 100 cigarettes per lifetime. There's also these less common terms, light and intermittent smoking. So light smoking varies, but some people say 1 to 10 cigarettes per day. Intermittent smoking is more like social smoking, so a person who doesn't smoke every day. And then very light smoking has been defined as no more than 5 cigarettes per day. So this is a review article I wrote with my colleagues at the Dana-Farber Cancer Institute and the Harvard School of Public Health, looking at historic, epidemiologic, molecular, genetic, and environmental aspects of LCINS. There's much that is still unknown, but this article encapsulates almost all of what we do know. And so I'll be talking a little bit about information from this review article and about other topics as well. So epidemiology, meaning who gets LCINS most often. And so approximately 2/3 of LCINS cases occur in women, making women who have not smoked more than twice as likely to develop lung cancer than men who have not smoked. It's more common among female patients in Asia than those in other regions of the world. And interestingly, over 55% of female Asian patients and more than 30% of female Hispanic patients diagnosed with lung cancer in the United States have never smoked. And there's some association with younger age. So about 75 to 80% of younger patients with lung cancer have never smoked. But when you look kind of at the median age of diagnosis between people who have smoked and people who haven't, it's about the same. So one thing that is clear is that smoking rates have been steadily declining. They vary widely across the United States and the world, but generally speaking, smoking prevalence among adults reached an all-time low in 2021 when it was 11.5%, and that was down by more than 2/3, 42% decrease since the Surgeon General's report first linking cigarette smoking to lung cancer and heart disease in 1964. And the national smoking rate is projected to fall even further to 7.5% overall by the year 2065. So this graph just shows how much smoking rates vary across the United States, with the highest smoking rates in the southeastern U.S. and Kentucky and West Virginia have up to 22 to 25% of adults reporting that they currently smoke. And lowest rates are generally among the north and southwestern United States. So talking about LCINS as a distinct cancer type, so as its own cancer. So first, no one has collected data to quantify whether there is an absolute increase in LCINS or whether it just represents a greater proportion of lung cancer cases now that smoking rates are going down. However, there was a study of over 10,000 lung cancer patients across 3 major cancer institutes about 10 years ago now, showing that the proportion of lung cancers in patients who did not smoke increased from 8% in the years 1990 to 1995 to about 15% in the years 2011 to 2013, suggesting that the incidence of lung cancer in people who have not smoked is increasing. And then you can see, and that's non-small cell lung cancer in the blue. And then you can see in contrast, small cell lung cancer in the red didn't show much of an increase across this time period. And furthermore, if considered a separate cancer type, LCINS would rank 5th most common cause of cancer deaths worldwide, and 8th in the United States, with about 20,000 deaths attributed to LCINS in 2023. So here, I thought it would be helpful to go over some of the molecular features of LCINS, being that these are terms that patients encounter all the time, more and more. And so I think it's useful to review in the context of contrasting, LCINS with tobacco-related lung cancer. And it's important to note that, one is not better than the other. It's just a matter of looking at exposures and how these two types of lung cancer are shaping up to be different. And so first aspect that's quite different is histology. So histology refers to the way that a cancer, or in this case, a lung cancer, looks under the microscope, the way that the lung architecture and the tumor architecture looks under the microscope, and how pathologists use that information to classify lung cancers. And so I'll go over these terms in a bit more detail after this slide, but for LCINS, primarily speaking, about more than 90% are adenocarcinoma histology, whereas tobacco-related lung cancer, you certainly have adenocarcinomas, but also squamous cell carcinomas and small cell lung cancer. Perhaps one of the most distinct features of LCINS is this enrichment of targetable driver alterations. And what that term really means is that there is a genetic change, a single genetic change in a tumor cell that's present in all of the cells and is directly targetable with a medication. And that once you inhibit that gene or the product of that gene, the tumor cells die and the tumor decreases. So the tumor is dependent on this driver alteration. And so these are things like EGFR mutations and ALK rearrangements, which you may have heard of. And in LCINS, they're present in about 80 to 90% of those tumors. And in contrast to tobacco-related lung cancer, the numbers are more like 30 to 50%, and these consist mainly of KRAS mutations and some other mutations, mainly KRAS. And so tumor mutational burden, this is just a measure of the number of mutations in DNA or across some genes in a lung cancer. And so in LCINS, this is fairly low, 0 to 3 mutations per megabase. And then when you look at tobacco-related lung cancer, up to 10-fold higher, and in some cases much, much higher than that. And that's just reflective of tobacco smoke inducing mutations in DNA directly. So it's not surprising that it would be low in LCINS and higher in tobacco-related lung cancers. And then you have PD-L1 expression, which is a biomarker that patients have heard of a lot, particularly in the context of immunotherapy. And so in LCINS, I'll explain what PD-L1 is, but in LCINS tends to be low. Tobacco-related lung cancer tends to be high and highest with current smoking. And interestingly, in the case of TMB and PD-L1 expression, both of them are positively correlated with pack years of smoking. So the more pack years of smoking, the higher the PD-L1 expression, the higher the tumor mutational burden. And then when you look at genomic mutational signatures, these are things that are primarily used in the research setting right now, but it is possible to detect smoking signatures, among others, in tumors. And so, not surprisingly, in LCINS, there are absent smoking signatures, and in tobacco-related lung cancers, you can detect a tobacco signature, which consists of single base substitutions. And what's interesting about this in particular is that for cases where patients did not smoke but reported a heavy exposure to secondhand smoke, smoking signatures were not found to be detectable in those tumors. And then lastly, what we call immunogenicity, or just how attractive a tumor is to the immune system, how much it sticks out to the immune system. For an LCINS, these tend to be immune cold and immune hot in tobacco-related lung cancer. And again, reflecting just, tobacco carcinogens themselves inducing mutations and immune responses. So when looking at histology in lung cancer, it can be helpful to just have this background, and these numbers are largely estimates, but just to get a general sense, there's two main types of lung cancer. There's small cell lung cancer, which is a neuroendocrine tumor, and there's non-small cell lung cancer, which is about 85% of lung cancers. Small cell lung cancer is almost exclusively associated with smoking history, and non-small cell lung cancer can be either. And in non-small cell lung cancer, the two main types are adenocarcinoma, which we talked about, and squamous cell carcinoma. And so generally speaking, in people who have not smoked, and also people who have, adenocarcinoma is the predominant subtype. But for people who have smoked, they can also get squamous cell carcinomas. And just to give you a sense, this is what they look like under the microscope. So here's a small cell lung cancer. It's what they call a neuroendocrine tumor. The cells are kind of small and purple and very distinctive. And then within non-small cell lung cancer, you have adenocarcinomas that look relatively glandular. And then you have squamous cell carcinomas, which resemble more airway, lining of the airways and airway epithelium. And the reason this is interesting is because when you look, small cell carcinoma and squamous cell carcinoma, both of which are associated with tobacco exposure, occur in more central areas of the lung, areas where tobacco smoke readily reaches. And in adenocarcinoma, it tend to be more peripheral areas where tobacco smoke would not reach as readily. So what is PD-L1? I thought that this would be helpful just to look at. So PD-L1 is also called programmed death ligand 1. It's an immune checkpoint protein on tumor cells. So it's depicted here. And when it's bound to a protein called PD-1 on T cells, which are cells of the immune system that recognize and kill foreign cells and viruses and things like that. When PD-L1 is bound to PD-1, it prevents the T cell from killing that cell. So it's a checkpoint. But when you inhibit the binding in the right figure here, when you inhibit the binding of PD-L1 to PD-1 with drugs like Keytruda or pembrolizumab or Opdivo or nivolumab, people may have heard of these checkpoint inhibitors, you then kind of remove this inhibition and allow the T cell to kill a tumor cell, which is foreign to it. And so PD-L1 is often overexpressed in tumor cells to avoid the immune system and facilitate cancer growth. What we know now is that high levels of PD-L1 expression predict tumors that are more likely to respond to immunotherapy, or checkpoint inhibitors is the class of drugs. And we know that smoking-related lung cancer has higher PD-L1 induced by tobacco smoke. What's interesting is that even LCINS that have high PD-L1 scores, which is not common, but we do see it, typically do not respond to immunotherapy, just kind of reflecting the immune cold nature of these tumors. And then what is TMB, or tumor mutational burden? So it's the number of mutations found in DNA of tumor cells. And this is important because these mutations change proteins, and these changes in proteins create what we call neoantigens, which is just a word to say that it's a target for T cells to bind and kill those cells. And this generates an anti-tumor response. And so what you can see here is that, and I have explained, is tobacco smoke directly induces these DNA mutations. So here's a TMB high scenario where you have all of these mutations, these neoantigens, and then you have T cells that come and bind to these neoantigens. And these tumors are thought to be more immunogenic, and they therefore display higher response rates to immunotherapy. And in the case of LCINS, you have kind of this on the left, this low TMB scenario, where you don't have a lot of mutations, you don't have a lot of neoantigens, you don't have a lot of T cell binding. So just generally speaking, not a lot going on with the immune system in these tumors. What is striking about LCINS is this enrichment for targetable genomic alterations, as I spoke about a little bit earlier. And this is just a cartoon kind of showing some of the targetable genomic alterations you may be familiar with. EGFR mutations are fairly common, in fact, the most common in LCINS. There are also HER2 mutations. There are MET amplifications, which you can see here, also mutations. And then there are fusion genes. So this is just showing two of the common fusion genes where you have a protein that signals cells to grow that gets fused to a gene it isn't normally fused to. And this fusion partner promotes the expression of the gene that makes the cells grow in an inappropriate fashion. And so it kind of stimulates cancer cells to grow unrestrained. And so here, these are the landscape of somatic alterations in LCINS. So like I said, they're highly enriched, but what are they? What are these mutations, comprised of? And so this is just a simple pie chart, and you can look, and this is taken from recent studies in the literature that have looked at these tumors. So primarily EGFR mutations, as we talked about, and kind of getting into the details of that is a little bit beyond the scope of this talk. But EGFR mutations are the kind of largest component of lung cancer in never smokers. And the KRAS mutant lung cancer is interesting because the mutation that is found there is G12D, which is in contrast in tobacco-related lung cancer. The mutations are more commonly G12C or G12V. And then these fusion proteins here, fusion genes here, ALK, ROS1, and RET, also have HER2 mutations, to a lesser extent BRAF mutations, and then either MET amplification or certain mutations in the MET gene. And then this is just helpful to look at because this is kind of contrasting LCINS versus tobacco-related lung cancer. So here on this graph in the blue, these are people who have never smoked. These are people, and then kind of in the red, it goes from former smoking a long time ago, former smoking more recently, and then current smoking. And so what you can see in the case of the EGFR gene, that EGFR mutations are more common when people have never smoked. And then as kind of the smoking level increases, the rate of EGFR mutation goes down. The opposite is the case for KRAS, where the rate goes up. So as there's more smoking, the rate of KRAS mutation goes up. And then you can see kind of the same thing for EGFR as for ALK and HER2 and MET mutations in some of these fusions, where you have kind of decreased prevalence of these as smoking history increases. And this is a review that came out in 2023 talking about rare molecular subtypes of lung cancer. So some of the ones that I mentioned in the pie chart prior are kind of the more common molecular subtypes, but there's a whole bunch of rare molecular drivers. They consist mainly of fusion proteins, but also amplifications and some mutations. And generally speaking, these are more common in LCINS than they are in tobacco-related lung cancer, certainly with some exceptions. But it's just worth knowing about, particularly for these kind of rare oncogenic fusions. So next part is, are there risk factors for LCINS? And this is a diagram here that shows risk factors that are, pertaining to the environment, and then some that are pertaining to genetics. And so I thought it would be helpful to talk about the environmental risk factors kind of one by one, because this is something we get asked all the time, and then talk a little bit about genetics as well. And so on the left, for environment in purple, these are kind of thought to be modifiable risk factors. In other words, they can be changed. And then with genetics, these are thought generally not to be modifiable. Your genetics are your genetics. And so, with that in mind, I thought we could review the environmental risk factors and kind of what the data shows in terms of level of risk. So radon is an invisible and odorless gas commonly found in many basements in the United States. It's the second leading cause of lung cancer after tobacco. And, nowadays it's quite common for anybody who's selling or buying a house to test for radon. But in the older generations, that wasn't as common. It wasn't a known risk factor. And so many people, were potentially exposed. And it's important to point out that it's not only very easy to test, but it's fairly, relatively speaking, inexpensive to mitigate as far as things go in terms of mitigating things in houses. So it's something worth knowing about and testing if you can. And then secondly, secondhand smoke. So we know that secondhand smoke increases lung cancer risk in people who do not smoke. It's responsible for about 3,500 LCINS deaths. And as I mentioned, these tobacco-related mutational signatures have not been detected in these tumors. But what's interesting is that many epidemiological studies performed in the 90s and 2000s, early 2000s, established secondhand smoke as a risk factor. The effect sizes have been moderate, and so in most of these studies compared people who had a spouse who smoked with people who didn't. And what's interesting is that the molecular characteristics of secondhand smoke associated cancers are similar to those in people who have never smoked. So it's hard to tell what secondhand smoke is exactly doing. No differences in the rate of targetable alterations. And so, the effect is generally thought to be pretty modest. Occupational carcinogens, all kinds of things people are exposed to in the workplace with certain occupations. Gases, natural elements, certainly fumes and particulate matter, which I'll talk about a little bit more. And this particulate matter is also found, kind of generally speaking, in air pollution. And so the way that it's labeled is by the diameter of the particle. So if it's less than 10 micrometers, it's PM10. If it's less than 2.5 micrometers, it's PM2.5. And these things have each been associated with an increased risk of lung cancer. And then asbestos, this is kind of well established. We know it's associated with mesothelioma and lung cancer. risk. And the important thing to know is that the risk is greatly multiplied when combined with cigarette smoking. So air pollution. So air quality can be measured by quantifying the amounts of ozone, particulate matter, chemical pollutants in the air. And so particle pollution is a combination of small liquid and solid particles that make up dust and soil and acids and chemicals in the air. And so in terms of air pollution, the World Health Organization in 2016 estimated that about 6% of outdoor air pollution related deaths were due to lung cancer. And PM 2.5, as we talked about, so this is particulate matter with a diameter of less than 2.5 microns. And so these can reach very small airways in the actual air sacs in the lung by nature of the particles being so fine. And this has been associated with heart disease and lung cancer in people who smoke and also people who have not smoked. And within that, particularly EGFR mutant lung cancer, recently there's been an association that's been described. And then e-cigarettes and vaping, and we get asked this question a lot. Ultimately, we need longer term follow-up studies. We just don't know enough and haven't observed the exposure for long enough. And so the risk is really not known. It's likely dependent on what the vaporized liquid itself is made of, the device itself, and how people use it. So more to come on that. And then household pollution or indoor pollution. This relates primarily to indoor burning of coal and high temperature frying. And there people have observed dose-response relationships between exposure to these fumes and lung cancer risk. And this has particularly been seen in non-smoking women living in China and in Asia. And generally speaking, household pollution has been more significant for women. And that's thought to just reflect historically, women had spent a greater proportion of time in the kitchen. And so first I'll just start with prior chest irradiation. This is primarily for cancers such as Hodgkin lymphoma or breast cancer. We know that having prior radiation to the chest does increase the risk of having what we call a second primary lung cancer. In other words, a lung cancer that develops not a Hodgkin lymphoma, not a breast cancer, but a new lung cancer. The greatest risk is in combination with smoking. But we know that this risk kind of persists, up to 20, 25, 30 years after having that radiation. And somebody did a study of breast cancer survivors who received radiation, and they had a tenfold higher lung cancer risk than those who did not receive radiation. Diet, no consistent data at all to implicate dietary differences, but certainly studies are underway. And then prior chronic lung disease, so things like COPD, pneumonia, tuberculosis, these are all associated with an increased risk of lung cancer. It's just hard to kind of pinpoint the role of the lung disease because most of the patients with these lung diseases also have significant tobacco exposure. And then recreational drug use. So this is another question we get asked a lot in terms of marijuana smoking in particular. And the risk is unclear for a number of reasons. One is it hasn't really been studied in the way that tobacco exposure has been studied. And two is that there are cases and oftentimes where people who smoke marijuana also smoke tobacco, and so it's hard to kind of tease that out. Smoking opium, which is more common in certain parts of the world, we know increases lung cancer risk. So I thought I would just spend a little more time on air pollution and PM 2.5 in particular. And as I mentioned, PM 2.5 describes fine inhalable particles. The diameter, like I mentioned, is 2.5 micrometers or smaller. And what you can see is that the bigger the particle, the less far it can get in the lung, or the smaller the particle, further it can go. So in PM10, it kind of reaches just the larger airways, the trachea and the main stem bronchi here. For PM 2.5, it gets all the way into the lung, all the way out to the periphery, which you can see here, and even into the air sacs, as I mentioned. And then there's ultrafine particles as well that are even smaller. And so here, this is just a kind of a heat map of the United States looking at average annual PM 2.5 concentration, keeping in mind that the EPA annual average standard for PM 2.5 is less than 12. There's been some thought that that might be revised to between 9 and 10, but currently it exists at 12. And what you can see in the map is that there's a considerable portion of the United States that is well above that, and a pocket here in California. And so it's just kind of helpful to know when looking geographically at these levels. And then this is a worldwide map. This also came from the review. So the World Health Organization guidelines are even more stringent at 5 or less. And so what you can see in this kind of world map is that there are some places in the world that are considerably higher than that. And it's just good to keep in mind when we think about kind of the global effect of air pollution. And so now I'll talk a little bit about genetics, and this is my primary focus of research, and I'll talk a little bit about that as well at the end. So first, it's important to note this term germline. So anything that's inherited, meaning the mutation in DNA that you were born with, that you most likely inherited from either mom or dad, and can be passed on to future generations. That's called inherited or germline. And that's different from mutations that happen in tumors, like EGFR mutations or ALK rearrangements. So those are genetic changes that happen in the lung tumor only. They can't be passed down. They weren't inherited. They kind of happened in a cell over the course of a lifetime, and that they kind of live only in the tumor and in those cancer cells. But germline genetics are different. And this is when people talk about cancer predisposition, inherited risk, things like that. And so we know kind of by way of family history that that genetics can mediate lung cancer risk. And so family history of lung cancer, we know, can increase lung cancer risk in smoking and non-smoking related lung cancer. Either shared genes or shared environment or both are likely playing a role here. There are some hereditary mutations or germline mutations in certain genes that raise risk of lung cancer. Genes such as EGFR, there is a particular mutation called EGFR T790M that is found in families that have kind of a significant amount of lung cancer within the family. And we know that it's a very strong risk factor for developing lung cancer, and even stronger if people smoke, but even in the absence of smoking, very strong risk for lung cancer. But this is thought to represent a very small proportion of lung cancers, likely 1% or less, but is also so rare, and we know very little about the statistics of it. And then there are some other genes also that have come out of these larger sequencing studies. People have found that some mutations in some of these genes raise risk of lung cancer significantly. And then there's something called polygenic risk, and this has been looked at mainly in smoking-related lung cancer in big studies, tens of thousands of people. And what people have started to do is calculate these polygenic risk scores. And this is just kind of a aggregated influence of many mutations, each of which has a little bit of increased risk of lung cancer. And when you sum them all together, it can translate into a bigger risk than each individual one. This is still kind of a research thing people are looking at. It's certainly not ready for clinical use in lung cancer. And certainly we don't really know how to use it in lung cancers without tobacco exposure. And then, very likely interaction between genetic susceptibility and environmental exposures is at the root of LCINS. And this is just something to think about, when to consider genetic testing or genetic counseling. If you're wondering if maybe there's a hereditary component to your cancer or to your lung cancer. So generally speaking, in cancer, there are kind of hallmarks of hereditary cancer syndromes, and these are some of them. Perhaps you have multiple family members on the same side of the family that have cancer, either cancer in general or the same type of cancer, in this case, lung cancer. Earlier age of onset in relatives or the patient with cancer, and then 2 or more cancer types. So for example, breast cancer and lung cancer, or lymphoma, and colon cancer, or, just having 2 or more different cancers in the same person, definitely makes you think a little bit more about some sort of inherited risk. And so, if any of these apply to you, the first thing to do would be to find a genetic counselor in your area, and, kind of speak to that person who will take your family history, and decide if further testing is indicated, and what that would look like. And then, as we mentioned, these genetic environment interactions are likely to be key going forward. And so you have this genetic risk. There's a lot of different genes and a lot of different mutations, but you have this kind of inherited risk. And then you have environmental exposures. And we know that not everybody that's exposed to the same thing develops the same disease. And so this interaction of genetics and environment is likely at the root of the mechanism we're looking at here. And importantly, looking at this and trying to find who's at the greatest risk can open up opportunities to expand lung cancer screening beyond those with a smoking history. So treatment and diagnostic considerations, I thought this would be of interest as well, considering that we get asked these questions a lot. And just looking here, this point we've kind of hit a lot during this talk is that these tumors are enriched for these targetable alterations. And this is this pie chart again. And so what's important is that we recommend, or the NCCN recommends panel-based NGS whenever possible in lung cancer to uncover these alterations. And so what you really want to be looking for is a broad enough panel using next generation sequencing to maximize the chances that you'll uncover one of these alterations. And this panel-based NGS, to avoid going into too many details, it can either be DNA-based or RNA-based. And generally speaking, mutations like EGFR mutations and KRAS mutations are easily detectable or more easily detectable with regular panel-based NGS. It's the fusion genes that can be more difficult to detect, and oftentimes using RNA-based sequencing will uncover these fusions. And that's kind of illustrated in this figure here that came from the Rare Molecular Subtypes Review. When you look, the blue diamonds are DNA-based sequencing only, and the pink circles are DNA plus RNA-based sequencing. And when you look here and you look at these fusions, as most of them are, when they used only DNA-based sequencing, you can see the rate of detection here. And then when you add RNA-based sequencing to that, the rate of detection jumps up quite a bit. And the reason this is important is because if there is a patient who doesn't have a smoking history or has a light or very remote smoking history, meaning quit a very long time ago, didn't smoke all that much, or perhaps has never smoked, as we've talked about, that these targetable alterations are much, much more likely to be found. And so it's worth, taking a good look and uncovering as many stones as possible to identify these. And the reason that is important is because once you do identify a molecular driver, we call that genotype-directed treatment, meaning if you have an EGFR mutation, you'll get EGFR-directed treatment. If you have an ALK rearrangement, you'll get ALK-directed treatment. And so it's important to know, particularly in LCINS, what the genotype of the lung cancer is, because that's going to determine what the treatment should be. And this diagram isn't really important to look at, but just to kind of show you that you may be asked to undergo a lot of tests. You may be asked to undergo blood-based next generation sequencing or tissue-based, meaning it comes from a biopsy, and additional molecular tests after that to determine if one of these alterations is present. And lastly, prevention. Can we do anything about this? And so looking again at these lung cancer screening guidelines that we talked about, what are some categories of people that we can add to this to kind of expand the criteria and detect more lung cancers? And ideally, it should be people at high risk, but the risk may just be mediated by things other than smoking. And so we've talked about this, but here are some potential categories that can be added. Genetic risk or family history, certain occupational exposures, perhaps people living in exceptionally high pollution areas, people who have had prior chest radiation. And as we mentioned, combining genetic risk with any one of these things might uncover a group of people that's at even higher risk when they have both things, genetic and environment risk. And so what are some research studies? Myself and my colleagues at Dana-Farber are running 2 research studies looking at genetic risk in lung cancer. And I'll describe those here in case they're of any interest to people. But basically, trying to uncover genetic risk and trying to develop screening paradigms to capture that genetic risk. So these are the 2 studies that I'm going to talk about very briefly. One is called Inherit, Investigating Hereditary Risk in Thoracic Cancers, and one is called the Young Lung Cancer Study. So Inherit is a study we are running in collaboration with the GO2 Foundation for Lung Cancer and the Adario Lung Cancer Medical Institute. And this is a study that we're looking to follow patients with inherited genetic risk. So either known mutations or a very strong family history of lung cancer, to A, quantify their risk of lung cancer, B, develop a screening paradigm based on this risk, and C, there's a discovery endpoint as well in terms of whether there are new genes or mutations that we can identify that increase lung cancer risk in patients or in their families. And so this is kind of just the broad structure of the study. Just to point out that there's blood collection. That's all that's, and questionnaires. That's all that's involved in the study. So there's a research blood collection. There's exposure and medical family history questionnaires, and then access to medical records. And then participants will get kind of germline testing for some of these genes if they opt into it and have results returned to them. And there's like 3 cohorts we're looking at: germline EGFR mutations, other mutations, and family history. And so feel free to go to the study website and fill out the information form to see if you might qualify. And if anyone is invited to fill this form out, and you'll be contacted by the study team when you do. The second study is the biology of young lung cancer. And so this is just looking at people who are diagnosed at age 45 or younger with small cell or non-small cell lung cancer. And it's the same type of study looking at genetic risk. It's also a website that patients can visit and fill out an eligibility form and learn about their genetic risk if they are found to have. And with that, I think I will close the talk, and thank you for your time and for your interest in this topic.